1, 2, 1, 2. Good evening, everybody. I know that the microphone, first of all, is not really necessary for the place we are in. You are not that far away from me, and I mean, the room is also not that huge. But of course, we are live streaming this all currently to Facebook, and the participants online also want to see and hear us. That's why the microphones, that's why the extra noise from me. But apart from that, welcome everybody. I'm super happy to have you here, those in person, and of course everybody who's watching currently on Facebook. And we are today already having our second pre-hackathon workshop, and today we are going to be talking about health tech, or more precisely, empowering teams for health tech or healthcare innovations. And before I give word to our main partners and also the leads for the workshop today, I am going to quickly use the opportunity to talk a bit about the hackathon itself. I hope those of you in attendance have already registered and plan to attend it, but still, for those online, I just want to say that, yeah, this is already going to be the 5th year for the Women in Tech Hackathon. And this year, our main topic is data, health, and intelligence. And the hackathon itself, it is a celebration of the International Women's Day and, of course, of women and technology altogether. But don't worry, that doesn't mean that guys are excluded. It is not just a girls' club, so everybody is more than welcome to join. Of course, there is one rule that each team that participates, you do need to have at least one female founder in the team. Teams itself are from 2 to 6 participants, but returning back to the overall hackathon theme, it's going to take place already this weekend from March 8th to March 10th. It's going to take place in a hybrid format. So there is an option to participate online, but of course it's going to be a bit more fun to join in person. And the in-person location, that is going to be the University of Latvia's Nature Building. So that's where we are going to be located. One thing I need to mention, usually, sometimes mostly in hackathons, there is the option to stay overnight. Since this is more of a hackathon for beginners in this thing, in hacking, and we do want to provide some sort of comfort and not really push you all in one room where you need to stay the night. We will be closing down the building each evening at 10 o'clock, and you will have the opportunity to head home, take a shower, probably continue work over, online, and then get back to us at the University of Latvia in the morning. So that's regarding the hackathon. And one more thing about it, if you haven't yet registered your idea or your team, or you're still even thinking about what's a hackathon, why should I do this, and should I even participate? Of course, there are prizes, there are main prizes, but we have several challenges from our partners as well. And today we are going to be mainly focusing on the challenges from our main hackathon partner, which is the company Novartis. And they have already 5 published challenges, so I would suggest going over them once you register and choosing the one you like most, and then, well, hopefully creating something along the lines of the challenge and, try to solve it. So that is that from my side. One quick thing I do need to do is share these slides over to Zoom, thus to Facebook. So a quick technical break for 2 minutes. I will be back in a moment. I'll continue talking, so you on Zoom, you understand that I'm not gone anywhere. That was the intro from my side, and I would love to welcome to the stage our 2 speakers from the evening, Agnese Jonāte, Healthcare Solutions Lead at Novartis, and Edgars Šķudītis, also Healthcare Solutions Lead from Novartis. Here you go.
So thank you, Pauls, for introductions. My name is Edgars. This is my colleague Agnese, and today within this workshop we would like to jump more in details regarding our challenges and introduce our company itself. What we do, what are the opportunities for new innovative startups within our company, within our cluster, and then we will jump into our challenges which are in our focus areas, which is cardiology, neuroscience, and oncology, and we will maybe try to explain why we chose these challenges, what are the solutions we are looking for, and maybe what are the future perspective on them. So without further ado, I will give floor to my colleague Agnese.
Great, thank you. Good evening, everyone. Yeah, Paulus will manage the slides, and there they are. Novartis, as Edgars mentioned, is innovative medicines company that making sure that every day Novartis is working on creating new clinical solutions for patients and making sure that patients, healthcare providers, societies are empowered to face very serious diseases. Yeah, so that's our purpose, and I already introduced you that with, and we can go further. Exactly as Edgars already mentioned, we have some few therapeutical areas what we focus on. And at this point, we focus on cardiovascular diseases, immunology, and neuroscience, and oncology. And actually, all the 5 challenges that Paul's mentioned, we have raised up, covers all the therapeutical areas. Just a little profile information about Novartis. 78K employees, almost 300 million patients reached, and a lot of nationalities working for Novartis, so very diversity company. Of course, such a big company has very serious strategy underneath it, and of course, the priority always is the high-value medicine for patients, but not only, and I have highlighted the section about, the innovation, and I would say more than ever, Novartis is prioritizing the innovation, data science, digital solutions, and different kind of opportunities for patients. Okay, we can move further. And what does it mean? So what does it mean innovation for Novartis? And you most probably have heard this, beyond the pill innovation, because now the pharmaceutical environment cannot only think about this clinical side, how to provide patients with better medication, even so it is priority. We have to be a very strong player in this whole healthcare ecosystem. It has to be beyond the pill. It has to be about the digital, or not only digital, different kind of solutions for the whole healthcare ecosystem. And Novartis believes that digitalization, technology, and data can transform the way how we see the patient. And what is important, I think, for all of you to know that the goal never is to create more innovation. It's more about how to do this more effectively and how to deliver impact at the scale. And we have to do it, together. We cannot do this only alone. So this is this ecosystem. What we are having there is patients, tailored and precise solutions for patients, meaning different kind of mentoring, monitoring tools, patient management. Of course, healthcare system, how to deliver the best result by participating in the policy-making decisions, closing gaps in the whole healthcare system. And then there's Novartis and partners. How can we deliver the best and execute the highest impact on the healthcare ecosystem? So how do Novartis mobilize the ecosystem and generate this triple win? There's 3 focus points that we have to reference the partner and to be the reference partner in digitalization and of the whole healthcare system. we have to put the data science at the service to benefit the patients. We have to work together with the healthcare system stakeholders, public, private organizations, and startups as well, to really co-create and innovate these solutions and address these fundamental challenges that we have in the healthcare system. And this is, I wanted to briefly introduce that we have really hands-on practice with some innovative solutions and participation with EIT Health. This is a few years ago, actually, when the BIOM existed. Now it's a bit transformed more to BIOM Innotech. It's like an innovative hub of Novartis who is making sure that we can co-create, co-partner with different kind of startups and have the opportunity to expand our possibilities and give the startups opportunity to really have the networking possibilities and different kind of opportunities. We can go further. Yeah, there were 4 challenges, and we can move next. I just wanted to show that this open submission had 84 submissions. 9 startups were chosen, and Longenesis in the middle is our partner still, very solid partner in very actually looking perspective big project, Longenesis, who had this opportunity to be one of the winners. So it's a platform for opportunities. Okay, and now I think we can go to the challenges. As Paul and Edgars mentioned, we have 5 challenges. And let's say this today, we just want you to introduce you with these challenges, maybe see the background where these challenges come from. If you have any questions, you can ask them, or maybe if we won't be able to answer them, you can, we can talk about that on Saturday or Friday. So hopefully these challenges will be attractive enough for you, and I think they're interesting to be chosen. Okay, so cardiovascular challenge, we can go further. Just a little bit about statistics from the 2021. This is OECD data, but it haven't changed, unfortunately, a lot now. It shows the main causes of death in Latvia is cancers, which is oncology, and Edgars will be talking about that, but I'm gonna talk about these circulatory system diseases, which is ischemic heart disease, which is known as heart attack, and stroke, which is known as well as insult. Okay, we can go further. Yes, there's highlighter, and then there's one more. And maybe you will hear or see this term as atherosclerotic cardiovascular diseases, and that's an umbrella term for these mentioned diseases. And this cardiovascular disease are caused by these fat deposit fat deposit plaques, what are in our plaques in our blood arteries. And these plaques are caused by lipids, from different kind of lipids. You may have heard low density cholesterol, which is known as bad cholesterol, and high density lipoprotein and cholesterol, which is known as a good one. Okay, and this imbalance between these lipids can cause these plaques in the arteries, and these plaques, you know, eventually grow bigger, and then they block the arteries and blood possibility to flow, and that can cause heart attack or stroke, and which is very dangerous, that you, before any kind of cardiovascular event, you won't, the human don't don't have any obvious symptoms about elevated LDL-C. So it's very important to do screening or any kind of risk assessment, especially if you are in the high risk group. Okay, we can move further. Okay, this is a slide diagram which my medical colleague said I had to put in just to show the correlation between the LDL-C number and actually causes of death. And I mentioned before that you really should be aware of your LDL-C, which causes these plaques in arteries, if you are in the risk group. So this is actually where the challenges start. How do you know that you are in the risk group? There's different kind of approaches in the world, how they're calculated. But in Latvia, we use this score table, which is approved by Cardiology Association in Latvia. And it's evaluated by 5 factors: age, gender, smoking, habits, cholesterol, and blood pressure. And this calculates what risk you are at. And LDL-C management, which can happen either by changing the lifestyle habits or medical treatment, is very crucial intervention when we talk about any cardiovascular disease possibilities, because it can really distance these cardiovascular events. Okay, we can go further. And talking about this risk assessment, who does that? When a patient goes to general practitioner, that's family physician, and if the patient is plus 40, you see the plus 40 is starting the risk group, he should create these risk factors and evaluate what kind of risk the patient is. But for example, the patient goes for any kind of reason at his physician, and physician prescribing to do the laboratory test just as he might or might not be in the risk group, he says, okay, well, let's do the LDL-C. And when the results come back, and as we know, we do receive them ourselves as a patient, with this LDL-C number, it's quite different as it is with other indicators, what we can see, because the deviation is not shown by underlying the number or some kind of highlight. It only says that there's this table, and according to these risk factors, you can see either is it too high, or should you be aware? So basically, patient won't ever have any clue. Either is it too high, or he should take some action, or no. And this is where the challenge really starts, because this would be, of course, the job of our general practitioners. They should, first of all, if they notice at all this number, and if they have some valid record of your risk assessment, then of course they can act, reach the patient out and say that this is deviation and we should proact and have some treatment or lifestyle changes. But if he does not, this patient really keeps in the big risk of cardiovascular events. So that's basically, we can go further, is our challenge. So what solution would promote cholesterol screening to the patients, allow the doctors and the patients effectively monitor the cholesterol level and track their treatment targets and progress, and increase the adherence to prescribed medication? So that's the first challenge in cardiovascular diseases. Next is from the cardiology to neurology, and it's multiple sclerosis challenge. What is multiple sclerosis? Is the central nervous system autoimmune condition that happens when the immune system attacks the brain and the spinal cord. And this is actually one of the most disabling diseases in neurology. And what is different from some other chronic diseases, it's affected by mostly young adults and females. So onset, it can be happen from the age 20. And currently there are 2,700 patients in Latvia, and the symptoms can be very various, very different, for very mild symptoms to some patients, to other who really struggles and have some disabilities over the time, hard time, challenge to walk or talk, and it really affects their quality of life. There are some symptoms we show there. That's fatigue, and if you know what's fatigue, it's basically that no matter how much sleep you have, you cannot, you still feel mental and physical exhaustion, which can, of course, be very awful. Depression, vision problems, sexual dysfunction, muscle-related symptoms, which can lead to really functional disabilities that patients need to use assistive devices as cane and wheelchair. Bowel and bladder symptoms, vertigo, which is balance dysfunction, and cognitive dysfunction. And as you can see, it's very obvious that all these symptoms really have a mental effect on the patient, and emotional. So these patients are very in need of emotional and psychological support. So this is our challenge, basically, because these patients, as I mentioned, they're chronic diseases. The chronic disease means that they are, it's not deadly, but it's manageable, but you have to basically live with that your whole life. So depression, grief, anger, behavioral changes are very caused by the factor that it's kind of, this disease is like a fear of unknown. They don't know what's the life expectancy, what they can expect in 2 or very short distances year, what kind of disabilities this disease will bring to them. And it's the data and studies show that patients with at least one of these kind of mental disorders shows significantly worse adherence. And adherence to any kind of chronic disease is very crucial, because if you want to manage and if you want to distance this disabilities, what I mentioned as disability to walk or talk or do any kind of social activities, is very crucial. So that's our challenge. Okay, and I have some existing barriers as well, because there is no centrally organized support for psychological support for these MS patients. There's still existing this stigmatization in the society and lack of knowledge about multiple sclerosis. And that leads to sometimes these patients losing their jobs, and they're young patients. They really could work and do, because these are kind of like phases when these symptoms attack them. But because of the stigmatization in society, they really lack these opportunities to work and be fully capable of being members of our society. And that leads, of course, to some significant economical burden and unemployment. So that's our challenge. What solution or tools, because really they're young adults, could provide this mental support for patients with multiple sclerosis. Okay, that's from me. So thank you for listening. And Edgars, you're welcome to introduce with oncology.
Yes, thank you, Agnes. Thank you. That was wonderful. So before I get to these challenges, I would like to also give a little bit of background what's happening in oncology in Latvia. So you can move to the next slide. So this is an overall picture in Latvia. So unfortunately, it doesn't look good, because if we look after the European Cancer Information System data, each year in Latvia, it's around a bit more than 600 new cases of a cancer diagnosis, which is about 7% higher than EU average. And if we look at the statistics about mortality rates, we can see the red one is Latvia, and we have one of the highest in Europe, and the purple one is the average. So in Latvia, mortality rates between year 2011 and 2019 only decreased by 3%. The average in Europe was 8%. And unfortunately, mortality rates for men in Latvia is the highest in Europe, and in women, this rate is 12% higher than average. And if you can move next. And if we look at what exact cancer types are most dominant in Latvia, then as we can see for men, it's prostate cancer, lung and colorectal. And for women, the leading cause is breast cancer, about 25%, and for men, prostate cancer is 29% around. So if you can move next. So what we can do to improve this situation? So early detection is the key, because if we early detect the cancer, then we can improve the overall quality of life of this person and reduce the need for aggressive treatments. And state has funded, and we have state-funded screening procedure and screening system in Latvia for several types of cancer. Here you can see a summary of these screening procedures. For each cancer, it's a little bit different. Each cancer has their own target group depending on age or gender, and how this screening is being performed. For example, for cervical cancer, women starting from age 25, 28, and then every 5 years, it will switch to every 3 years, will receive a letter which invites them to go to gynecologist who takes a sample, and then you do the lab test, and then that's the screening procedure. We are currently at Novartis very focusing on breast cancer because it's a bit more difficult, because in breast cancer, women starting from age 50 receives physical letter at their registered address, which tells them that you should do screening. There is no scheduled appointment, there is no place mentioned where you can do this, so this needs to be proactively done by the woman herself. And regarding colon cancer and prostate cancer, it's two-way communication, because each of these patients, for colon cancer, the age starting from 50, and prostate cancer men starting age from 50, can go to the GPs. And for example, they are wondering, maybe I should do the screening test, and GP sends them to do the lab. Or maybe GPs ask the relevant questions to them, and then they find out, okay, maybe for colon cancer, I need to provide fecal matter to the lab, or for prostate cancer, you just add one additional marker to your blood lab. So next. And so how it looks in Latvia. So these are the data starting from 2022, and the orange columns are last year's data, but unfortunately, officially, we have only data starting from January till September. We are still waiting for official data for the full year. So the blue line is the EU guideline, how it should look like. For prostate cancer, it should be around 70% as well, but it's not really well defined now at this moment. And the green line is the target for 25 across the year 25 across the Europe. It's very optimistical to be honest, but we'll see. And as you can see, for example, for cervical cancer, we can see a major improvement. starting from 2022 for 47%. Last year, through 9 months, it was over the European guidelines. But unfortunately, it's a bit less optimistic if we look at the breast cancer, because it's around only 40%, and for colorectal cancer, it's only 9%. But to be honest, I'm a bit doubtful about this data, because it's around 19 year before, but we will see when it comes, when we have the full year information. So please, next slide. So, and when we are focusing on breast cancer screening, we are thinking maybe there is some region in Latvia which is falling behind, and maybe we should focus only on those regions. But if we look at the map itself and the screening activity, we can see that across the whole country, the screening results are very similar. It's around 40–50%, which is well below required 70%. And in Riga, of course, it's a bit lower than in other regions, because Riga is more dense in terms of population. And also, as I said, these letters are coming to your registered address. And if you're living in Riga, maybe you are switching your home addresses, etc. So these letters, you are not receiving these letters. And the state performed a revision of the screening situation in Latvia, and they identified main reasons why those results are so low. So first few reasons are something we cannot impact, only if maybe you can tell everyone they should study to become GPs, because we currently in Latvia have insufficient number of GPs, and critical number are already approaching the retirement age. If you can click next. But there are some reasons we can impact, some causes. So, and this is about screening communication. Because as I already before said, screening is a physical letter. It comes at your home. I asked my mother, so because she's well in this target group, she has lived at the same house for 20 years. So have you received last 8 years, each letter comes in each 2 years, so 4 letters. Have you received 4 letters? She said she received 1. And then I asked her, did you perform the screening check? And she said, you know, they didn't show me the location, they didn't give me the time, so I needed to do it all by myself, but I have to work, so I didn't do that. So, and I think this is a big problem for a lot of women in our country. This is outdated forms of communication. Last year they started to send emails, but only then if your email is registered in latvia.gov.lv site. Do you have registered email there? I really doubt that I have. So how they can receive those letters? So this is the reason. This is something we want to look at it. Maybe we can find some kind of solution. Also, barriers to access screening, for example, long queues. There is a site where you can see all the locations where you can perform those mammographs or screenings, and how long a queue you need to wait for this screening checkup. In some clinics, the waiting line is 150 days. In some clinics in Riga, waiting line was 5 days. Does these women know that they can check up? Because, of course, if you're thinking, okay, I will do my screening check, I will go to the largest clinic. For example, in Riga, it's Ars, for example, and there was this waiting line more than 100 days. But, for example, in some smaller clinics where also these tests are available, the line was only 5 days. So maybe we also need to think how we can show and provide information for this woman, where to go, where the waiting line is smaller and shorter. And the last one, there is no uniform and clear procedure for reporting and receiving results. How these women receive those results? Because if there's some kind of finding, it's really important for them to go as soon as possible to the specialist, to the oncologist. So do they receive text messages? Do they receive an email? Do they go to the GP next time and GP says, okay, we have found something, you need to check it. So also there is no unified system here in Latvia. So these are the things we are trying to tackle. So in the next slide, so this is the first challenge. So seeking for a solution to assist in the organization and planning of screening visits. We are focusing on females for breast cancer, but also we can broaden this up for colon cancer and also men for prostate cancer. And this is something the state is also thinking about. And currently there are several work groups who are looking for also solutions, but we understand that this is really important. And if we can find together with you some kind of meaningful and really useful solution, we then can go communicate with the state and maybe for future perspective implement the solution countrywide. Because this is something we are communicating and they're really asking, if you have a great solution, please let us know and we can think about it. So, okay, next slide. And the second challenge in oncology is about the regions. Because as we can see in the map, this is mortality rate from oncologic diseases across the regions. And as you can see, the eastern region is much darker red than the rest of Latvia. This means that there are differences between regions. And this can be caused by difference in the cancer care quality, difference between specialist availability. If you can go to the next slide, please. And that's partially caused because Latvia has really centralized cancer care. About 80 to 85% of all cancer oncology patients are being treated in oncology center in Riga. Some part of the remaining patients are treated in Riga Šķudītis University Hospital, which is also in Riga, and remaining patients only have two options. Basically, it's Liepāja, which is the western city of Latvia where we have oncologists, and Daugavpils, it's the eastern city. So basically, there's no more options for high-quality oncology care. And of course, between these hospitals, the quality also varies, and the information transfer is not optimized. And also for pediatric cancer, for children, we have only few cases in Latvia, and we need to strengthen its collaboration with European cancer reference centers. And lastly, data collected by different regional institutions and healthcare providers are very fragmented because each hospital basically has its own data storage system, and they are not connected between each other. And for example, if patient changes hospital, for example, from one city to another city, there's a possibility that the doctor had all of its patient history written by hand, and when he goes to the new specialist, some of the test results, some of the procedure history can be lost in the process. So this is something we want to tackle also. And please, the next slide. And this is our solution, which we are asking for. Because there are different systems in hospitals, we have tried to communicate with them. It's really difficult because they have their own digitalization plans, etc. But maybe you can think of solution which would be like a plug-in or an add-on in the already existing digital health systems, which could improve and encourage the sharing of experiences and data. And this could include sharing patient data, sharing maybe difficult patient cases between the specialists, sharing experiences, sharing advice, sharing knowledge. And this maybe could, and somehow this could be all included in this one solution. And now we are looking only in Latvia. So how we can improve this communication between the regions. But as we saw with the pediatric cases, the next step would be going across the borders, maybe to link with other bigger cancer centers in different countries. And this is something we are really looking for, and this is a problem not only with us. I also spoke with our Lithuanian colleagues. In Lithuania, it's the same problem. In Estonia, it's not a problem because, as you know, they already have this digital e-health, and this is already established there. And we are also looking there, but as I said, maybe you have the solution in your mind which could help us with this. And the last one, it's a bit more tricky because this is really important issue, high-risk patient groups. Because there are individuals who have these hereditary risk or genetic predisposition for cancer. This could be BRCA1 or 2 gene mutations, and this means you have a much higher risk to have cancer at much earlier age. And identifying these individuals and their relatives allows us to intervene earlier and to maybe catch the cancer at its earliest stages, and we can operate and we can cure it without the more aggressive therapies and maintain your quality of life. For example, currently there is no state-organized high-risk breast cancer screening in Latvia. But GP, if he notices that something is wrong, or maybe he knows your family history, he can send you to oncologist, he can send you to a radiologist to have these exams made. And for example, if you have these BRCA1, BRCA2 mutations, you should have first checkup already starting from 25 years. If we compare to the screening, it starts only from 50 years. So how much sooner we need to do something? And if you have these mutations and your grade 1 relative, so basically your mother or your sister have had a diagnosis of cancer, then you must already have checkups at 15 years of age. So this is really important. And then if everything is okay, then you need to have yearly mammography starting from age 30. So these things must happen, you must go to the checkups much sooner than than the screening programs ask. And this is our last challenge. Next slide. There is no next slide. There is slide. So we are looking for solution, and this is more focused on GPs, because if we look at the regions, if we look, so for example, if you are a young woman, you think you have in family some cases of cancer diagnosis, you will not go, I imagine, you will not go firstly to the oncology, you will go to the GP and ask what to do. What test should I take? So we would like to have a solution that could assist GP to helping them to identify these high-risk patients, and also to have them timely reminders that these patients need to have their next checkup. Because, you know, there are GPs with a lot of patients and they can forget that maybe this woman or this young man, because these BRCA1, BRCA2 genes can also increase the possibility for men to have prostate cancer. So GP should know that, okay, I had this high-risk patient, I need to check him, I need to send him for checkup. So this is our last solution, last challenge for, I'm hopeful you will find solution for us and we can implement it. So yeah, and the next slide is the last slide, so thank you. And I would also remind you that for our challenges, we have additional motivational prize for the best solution for any of our challenges. We will award additional 200 euros for you, and of course, a possibility to cooperate with us and implement this solution in Latvia, maybe in Baltics, Ukraine, because it's our cluster, and maybe even in Europe. So think big, sky is the limit, and we also be, me and Agnese as mentors on Saturday, yeah? On Saturday, so I hope to see you there, and you can book one-on-one times with me or Agnese. So thank you.
There's actually an issue right now with the live stream, so I don't know if there's a use of this microphone right now. But first of all, thank you so much. And if there are any questions from the audience regarding the challenges, regarding what was discussed today, feel free to raise the hand and use the opportunity. They are here, they're not running away yet, so maybe any questions?
It's fine. I think it's really fine. Don't feel pressured if you don't have any. As Edgars said, we are going to be available on Saturday, and really we'll try to help you however we can. And today there's coffee table behind you, so please feel free to have some snacks and beverages, and we will stick around here for some time, right? And well, thank you very much, actually, that you came here in today. We really appreciate this. And I don't know how many participants there were in online, but anyhow, so really appreciated to see you. We will remember you.
No, but really, from my side, I really wanted to thank the both of you. And I do have presents, gifts for both of you. So I think it's a round of applause for our speakers of the day. Thank you, Edgars. Thank you, Agnese. And of course, thanks really to all of the participants who joined here today. As Agnes mentioned, we will remember you. That's a great thing you came here. We really appreciate it. And I mean, use this opportunity right now, being right here. First of all, grab something, some snacks, grab something to drink, and mingle amongst each other. I know that some of you are probably learning in the same course and you know each other already, but others don't know you. So mingle with one another and discuss the possibilities of either building one of the solutions for these challenges or, you know, just building a team for the hackathon itself. So use this opportunity as you already came here. You have the knowledge regarding the challenges, and yeah, use the time. Snacks, drinks over there. As for the people online, thank you so much for joining in. I'm hoping the live stream is working right now. And thank you so much for joining in. My name is Paul Silinch. I did not introduce myself at the beginning. I am a project director at Riga Tech Girls and also the hackathon lead. So in case you haven't yet registered for the hackathon, I do hope you got some motivation, you know the challenges now, and you know there are prizes. So yeah, head on over to rigatechgirls.com/hackathon. There you will find all the necessary information and the registration links. And I will see you, first of all, at the hackathon. Second of all, tomorrow we are having a team formation workshop where we will, you know, continue working on the teams you might have and, you know, discussing the ideas and the solutions and the challenges, so on and so forth. That's it for the live stream. That's it from me. And yeah, enjoy the snacks, enjoy the drinks, and see you tomorrow at the next workshop.